Hello everyone, this is Dr. Saravanan, intervention cardiologist from KG Hospital, Coimbatore. Today I'm going to give you a talk on the latest updates in hypertension. See, in India, the incidence of hypertension is rising. About two-thirds of the deaths which happen in India are due to non-communicable diseases, out of which around a half are due to cardiovascular diseases. Cardiovascular diseases encompass three diseases per se. Basically, heart attack, which is what we call myocardial infarction, heart failure, and stroke, which we call paralysis. So, heart attack, heart failure, and stroke constitute cardiovascular diseases. Together, these three diseases cause around 18 million deaths worldwide, and they also account for a major portion of deaths due to non-communicable diseases in India. For these diseases, one of the important risk factors is hypertension. Hypertension, we know, is increased blood pressure. The normal blood pressure, what we label as 140/80, when increased blood pressure is what we call hypertension. That is increased pressure of blood vessels or increased pressure exerted by blood on the blood vessels. So that is what to simplify to say simply is hypertension. Hypertension in India, the incidence is steadily rising. Previously, the incidence of hypertension was around 12 to 15%, but now it has increased to around 30% in urban areas and around 25% in rural areas. And the gap between the urban and the rural areas is gradually reducing. So the incidence of hypertension is also peaking in the rural areas as well. What we need to understand about hypertension is, in India, hypertension is a disease of halves, not only in India, but also worldwide. That is, only half of the people who have hypertension know that they actually have hypertension. So it's a disease of halves. So half meaning only half of the people who actually have hypertension know that they have hypertension, around which only half of the people are treated properly with medicines, among which only half of them take the medicines regularly, and among which only half of them blood pressure is adequately controlled, that they attain target BP. So what we need to understand is hypertension per se is a disease of halves. So the most important thing that we need to understand is for hypertension is proper measurement. So hypertension is not only measuring BP in the office settings, that is in the hospital settings, but also there are entities called masked hypertension as well as white coat hypertension. Masked hypertension is where the patient's lifestyle is actually very stressful. So the patient's hospital BP may be normal, but the out of office BP may be high. So this leads to increased risk of heart attacks and strokes and heart failure. Similarly, white coat hypertension is one in which once the patient visits the hospital, because of anxiety, his blood pressure slightly shoots up. But even white coat hypertension is associated with increased risk factors for long-term hypertension. So that is the thing that we need to understand. And another thing that we need to understand is, though we say the normal BP is 140/80, for every 20 millimeter increase in systolic BP above 115, that is 115. So if the systolic BP is 20 millimeters higher than 115, the risk of cardiovascular disease increases by 36% and the risk of overall mortality increases by around 23%. So for every 20 millimeter increase in systolic BP above 115, that is 115, and every 10 millimeter increase in diastolic BP above 75, the risk of cardiovascular diseases increase by around 36% and overall mortality increases by around 20%. So with regards to BP, the lower the BP, the better. So that is the most important thing that we need to understand. As elicited by the recent SPRINT trial also, what they say is we have to calculate the patient's risk factors and not only treat BP as a number. That is, we have to take in account other risk factors. So we have to calculate the patient's 10-year ASCVD risk, that is cardiovascular disease risk. If the patient's risk is more than 20%, we target a BP of 130/80. And if the 10-year ASCVD risk is less than 20%, we target a more liberal BP of 140/90. So this ASCVD risk is calculated for age group mainly between 40 to 75 years of age. This is also the age group among which the incidence of hypertension is steadily rising. The latest insights which we have regarding hypertension is, we have all realized from historical evidences from patients as well as clinical trials that monotherapy is insufficient to control blood pressure. So all landmark trials from ALHAT trial, SHEP trial, accomplished trial, all the trials have shown that around only 20% or 20 to 25% of people attain target BP with monotherapy. So nowadays, the European Society of Cardiology as well as the American Cardiology College of Cardiology advocate a combination therapy, preferably an AC inhibitor or ARB plus a calcium channel blocker as first-line monotherapy for control of hypertension. So A plus C is the preferred combination for hypertension as combination therapy. So at the outset, to control hypertension, combination therapy is preferred. The combination being ACE inhibitor or ARB plus a calcium channel block. So two groups of drugs are usually preferred. If the patient fails to attain target BP with this group of drugs, then we advise them to add a diuretic. So A plus C, that is ACE inhibitor or ARB plus calcium channel blocker, and if the target BP is not attained, then we advise them to add a diuretic. Beta blockers are only indicated for specific indications like angina, anxiety, heart attack, heart failure, aneurysms, and atrial fibrillation and arrhythmias. There are specific indications for hypertension. They are specific indications because beta blockers don't reduce the central aortic pressure. They are only useful in certain specific indications and not recommended as first-line therapy. The first-line therapy is an ACE inhibitor or ARB plus calcium channel blocker. Monotherapy is indicated only for the very elderly patients, age above 80, very frail, and if the systolic BP is less than 150. Only in those indications is monotherapy advocated. With recent evidences, what we have understood is that hypertension should not only be tackled by medicines, but also lifestyle modification is at the core of hypertension management. I usually tell my patients salt, stress, and sleep. So always reduce your salt intake by around 2/3 or half. Suppose if you're taking high intake of salts, avoid additional added salt in the table, that like pickles, puppets, all these things increase the total salt intake. Also, ensure that you take adequate sleep. That ensure that you sleep adequately, at least 7 to 8 hours per day, and ensure that your stress is manageable. So salt, stress, and sleep are three things that are essential while attaining control of hypertension, along with appropriate pharmacological therapy. So control of salt, stress, and sleep along with appropriate pharmacological therapy will help us in attaining target blood pressure. And what you need to understand is what can be measured can be controlled. So that is something which I always tell my patients. Always check your BP regularly, not daily, but at least once in 10 days or once in a week. Check your BP regularly. So I'm once again reiterating, what can be measured can be controlled. So always advise your patients to go for ambulatory blood pressure monitoring or home BP monitoring. So the importance of ambulatory blood pressure monitoring and home BP monitoring cannot be underemphasized. They are very essential in ensuring compliance to therapy, and that patients can also be placed on appropriate medicines and ensure 24-hour BP control. While checking the ambulatory blood pressure, two things we must note, that is the late night dipping, that is nocturnal dipping of blood pressure, and the early morning surge in blood pressure. In early stages of hypertension, the nocturnal dip in blood pressure is lost, and that must be focused. We must focus on agents to which have 24-hour of action. And similarly, the early morning surge in blood pressure is responsible for the high incidence of strokes. So controlling of nocturnal dip and early morning surge will help us in controlling the blood pressure. Always focus on agents which give us 24-hour BP control, and ensure that your patients take the medicines at the appropriate time. Always give them a BP tracker and ask them to check their BP once in 15 days or once in 10 days at home. Measure your BP, control it, and live longer. Thank you.